Hello dear students, we'll discuss a topic today, again one of the groin hernias, which is very important. Just look into that. See that here swelling below and lateral to the tubercle. That's the typical of femoral hernia. Inguinal hernia is above and medial to the pubic tubercle. Femoral hernia is below and lateral to the pubic tubercle. Obturator hernia is much below. Inguinal hernia is in front of the inguinal ligament, passes through the external ring. Femoral hernia is behind the inguinal ligament and pubic bone through the femoral canal, medial to the femoral vein. Obturator hernia is behind the pubic bone through the obturator canal, adjacent to the obturator membrane, as obturator internus muscle. So this is femoral hernia. Femoral hernia is common in females. Overall, in females, inguinal hernia is common. But if you compare interstitial hernia, inguinal hernia and femoral hernia, interstitial hernia is common in females. Right-sided femoral hernia. Common in females, inguinal hernia is above and medial to the pubic tubercle. I already told it's retort shaped. It comes like that, retort shape. Richter's hernia is part of the circumference of the bowel is involved. So they don't present with obstruction, but they present with the strangulation. Strangulation without obstruction is Richter's hernia, common in femoral hernia. So obstruction will not be there, but they will have diarrhea, severe pain, toxicity, but they pass loose. They will have motion or the loose stool because of the ischemia there. Mucus discharge will be there. Loose stool, bloody stool will be there. There is the Richter's hernia is common here. 20% bilateral, always acquired. That is not a primary or congenital hernia. It's not congenital hernia. Indirect inguinal hernia can be congenital or in a preformed sac. It is not so. It's always acquired. Same like direct inguinal hernia is usually acquired. This is always acquired. DD is inguinal hernia, clocket node enlargement, lipoma, femoral aneurysm, psoas bursa, saphenaverics. All these occurs in this area. And remember, this is the it's a short note for enumerate differential diagnosis for femoral hernia. And sometimes a long question also will be asked in the UG. Discuss the differential diagnosis for femoral hernia. So each one points you have to put all these conditions: inguinal hernia, above and medial, and features. Little bit briefly. Colquitt lymph node, where it's located, lipoma, femoral aneurysm, psoas bursa, saphenaveric. All this a little brief highlighting of each conditions are important when it comes as a main question. If you short note, just mention. So this is of exactly, see that. This is the inguinal hernia, this is the femoral hernia, this is the obturator hernia, this is the pubic bone, femoral vein, this is the femoral canal, this is the external ring actually, this is the obturator canal. The retort shaped here, see that, retort shaped. This is how exactly it looks like. So management is, see that, management is surgery, Lockwood low approach, McAvedy approach, high approach is Lothian high approach. Vertical, Equate is vertical in emergency. What is in the inguinal approach? Lothian. Henry is bilateral Henry approach, suprapubic approach, all midline approach you can go through. Laparoscopy approach is ideal currently. Treatment repairs are Cooper's ligament repair. That is inguinal ligament and Cooper's ligament are sutured. And Lothian repair, conjoint tendon is to the Cooper's ligament repair is done. Mesh repair, plugging of the mesh is done or preperitoneal mesh is placed. So this is the common standard now. This is repair done, one of the repair, Lothian repair, another repair. So this is other repairs you can do. Or midline or horizontal, Henry, bilateral femoral hernia, entirely cover it. This is also possible. Mesh repair is the standard thing. You have to remember. It's very common. It's the right side. Very common short note asked, many MCQs can be asked here. And surgical anatomy you should know. Retort shaped hernia, it is very important. Strangulation is common. Richter's hernia, strangulation is also common. So all these things are quite. Surgical anatomy also very important. Remember, it's a main question also. Surgical anatomy of femoral hernia. Discuss differential diagnosis is the main question. Small short management of femoral hernia. Surgical management of femoral hernia is a short note. Many short notes may be also asked. Some MCQs. Oxy also can be put here. So it's a very important topic. Remember, femoral hernia. So answer the MCQ. Herniation through a gap in the lateral ligament is called as Nara's femoral hernia, Laugier femoral hernia, Cooper's femoral hernia, Clockett's femoral hernia. Lothian repair for femoral hernia is mesh repair by tugging, Cooper's ligament to inguinal ligament approximation, conjoint tendon to the iliopetal ligament approximation, and laparoscopic mesh repair. Find out the answer, put in the comment box. I'll get back to you. Students, so please go through my SRB's clinical methods in surgery, current edition. It gives a video like the examination of the different clinical situations. It gives a detailed examination method, including history taking of swelling, ulcer, hernia, inguinal swelling, mass abdomen, breast lump, thyroid, neck swelling, salivary glands, all topics, including briefly trauma, how to approach orthopedic briefly. Then it also includes the instruments, specimens, images, briefly operative surgery, entire thing clinical method with a lot of photos, illustrations. Each condition's photos are there. It's very clear. And analysis, history taking, detail, examination, general examination, history taking, history of present illness and past history, current history, treatment history, drug history, local examination, inspection, palpation, percussion, auscultation, clinical diagnosis, differential diagnosis, and briefly in a table form, all differential diagnosis. But it doesn't contain treatment aspect because clinical surgery book only for clinical surgery, analysis and differential diagnosis. So treatment should be checked in detail. Principles of treatment should be checked in the manual, my SRB manual of surgery. So this is basically clinical book with the videos of each examination, with all illustrations, principles, different methods, different techniques, science. My service manual of surgery current edition gives a CBM syllabus, entirely covers all topics, general surgery, endocrine, surgery, thyroid, breast, GI surgery, urology, cardiothoracic, neurosurgery, then other topics, arteries, disease, veins, its principles, methods, clinical methods, treatment, complications, approaches, with the quotations in the each page. It covers entire thing, including treatment principles, brief operative procedure also, not in detail. And it also covers briefly instruments, images, anesthesia, briefly oncological aspect, and daycare surgery, audit, surgical audit, metabolic response to surgery, pain management, everything covers as far as required for the CBM syllabus for UGs, PGs and consultant, coming consultant also, with the illustrations, photos, a few video lectures and a lot of MCQs online for each chapter with the QR code. Lot of MCQs for each topic, so each chapter it is there. Covers everything for UGs, PGs, CBM, MCQs, NEET exam, whatever required thing. Please go through it. Very, very useful book. My operative surgery, extensive voluminous book, 2-volume book, mainly for postgraduates and learning surgeons. All procedures, including major surgery, GI surgery, general surgery, thyroid, breast and other things, include briefly gynecology surgeries, with step-by-step illustrations photos, more than 10,000 photos and illustrations are, and which covers everything for to learner. You can, before surgery, they can go through my book and have a step-by-step for the all surgeries, whatever common surgeries, major surgeries, it is there. You can always go through that in detail. Explanations are there. My small atlas of tissue approximation with the videos shows clearly with the principles how to suture tissues. Dissection and tissue approximation, there are two parts in surgery. Dissection is a principle, essential. After dissection surgery, you have to approximate tissues, deeper layer, skin, softer tissues, everything, bowel, GI, everything. So this principle of tissue approximation clearly given in this book with the videos of it, including laparoscopic tissue approximation. So you can always purchase that and go through that. Very, very useful thing to develop the skin, which is essential for all surgeons. Students, I also request all of you subscribe my website, both in YouTube, Instagram and so on. My DigiNow lectures to the JP publisher covers around 220 lectures in detail as far as CBME syllabus, from general surgery to specialty, urology, clinical examination, cardiothoracic, neurosurgery, all topics, GI, rectum, anal canal, colon, esophagus, liver, pancreas, breast, thyroid, neck, salivary gland, general surgery, artery, vein, everything in detail, all topics, theoretical aspect, surgical principle, operative surgeries, the examination, clinical examination videos also. It covers 220 lectures, covers everything. 1 year purchase you can do. It gives detailed thing about explanations with wherever MCQs are required. You can make use of it and you can learn surgery properly as far as CBM syllabus and academic wise also. It gives lot of information towards the surgical field as such. So students, I hope you have understood this lecture very well, and also you can go through my books, all these books, with including DigiNow and lectures. Thank you very much. So students, I hope you have understood femoral hernia. It's very, very important, especially in females. So thank you so much.